You don't stay in emergency nursing for over a decade without picking up on patterns, clinical ones, emotional ones, and sometimes the kind that don't make it into the chart. Some rooms hold grief, some chaos, and then there are the spaces that carry something else, like the waiting room, where a little girl kept showing up, never admitted, never claimed, and every time she did, the footage broke. My name is Laura. I've worked night shift in a mid-sized trauma hospital just outside Cleveland since 2011. Triage starts slowing down around 2 a.m. The bar fights are winding down, the overdose calls are en route, but the lobby gets quiet. Mostly family members waiting on updates or sleeping upright in hardback chairs. But about 5 years ago, something started happening that nobody could explain. It started simple. Security called down, asking if we'd had a pediatric check-in they might have missed. A little girl about 6 years old, dark hair, light blue dress, seen around 2:20 a.m. near the coffee machine in the corner of the waiting area. I checked the board, nothing. I checked with the charge nurse, triage, even double-checked with EMS. No pediatric calls logged that hour. Nothing unusual on our end. Security said she was just there, playing near the vending machines, twirling in circles. I shrugged it off. Maybe a visitor's kid. But they swore up and down there were no minors signed in, no adults visibly accompanying a child. A week later, it happened again. Same girl, same time frame. This time she was caught sitting cross-legged in the hallway outside the trauma doors on camera. But here's the part that still makes me feel off. Every time she showed up, the footage glitched. Not in a spooky way, not like haunted movie kind of glitch, just corrupted files. Security would rewind to show us the timestamp, and you'd see the camera stutter, then go gray static, then jump forward a minute or two. At first we assumed it was bad wiring. It ran diagnostics. Cameras were checked, replaced, firmware updated. Still happened. And always the same thing. She'd appear sometime between 2 and 2:30 a.m., never interacted with anyone, never triggered the automatic doors, never showed up on badge access logs. We're a level 2 trauma center, meaning our cameras and access control systems have to meet state inspection guidelines. Every single access point is time-stamped, logged, and stored for audit. That's not superstition, that's regulation. HIPAA, CMS, Joint Commission. We don't mess around with data integrity, but none of it caught her entering or leaving. By the third month, it became routine for the night charge nurse to ask half-jokingly, "Did our girl show up again?" I'll be honest, most of us brushed it off as nothing. We chalked it up to faulty systems or late-night exhaustion. But deep down, even the skeptics started watching the clock around 2 a.m. I remember one specific night, a brutal one, 2 code blues back to back. We were wiped, sweating through our scrubs, gloves sticking to our skin, floors slick with saline and trauma blood. I had just sat down with a cup of weak coffee when security buzzed down again. She's back. I walked to the monitor station, still in my gown and shoe covers. They rewound the footage, and there she was, right at 2:19 a.m., standing in the middle of the waiting room, looking straight at the camera. I leaned in closer. Something hit me that I hadn't registered before. She was barefoot, clean, no dirt, no calluses, no bruises, just pale feet pressed flat against the cold tile. And then glitch, static for 10 seconds. When the feed returned, the room was empty. I started asking around, quietly. No official report, just nurse-to-nurse talk. Turns out, we weren't the first ones to see her. One of the environmental services ladies, Maya, said she once left a small coloring book on the coffee table during her shift. It was just something left behind in PEDs. She said when she came back to clean later that night, all the pages had been flipped through, the crayons were broken in half. We joked, we speculated, we rationalized, but we all kept watching, and every few weeks, without fail, she'd come back. I never once saw her in person, just through that damn screen. Until one night, it was a Wednesday, right before Thanksgiving. Slow shift, light snow outside. Around 2:10 a.m., I walked out to grab a bottle of water, just needed a breather from the ICU hold we were boarding in the trauma bay. And I saw her, not on the camera, in person. She was sitting on the floor next to the gumball machine, legs tucked up under her, head tilted like she was waiting for someone. I froze. Every rational part of my training told me what to do: engage gently, assess safety, determine guardianship status. I stepped forward and said, "Sweetheart, are you lost?" She didn't answer, just stood up, turned, and walked into the trauma hallway. The door was badge access only. I didn't hear a beep. I didn't hear it click open, but somehow it did. I ran after her. She was gone. And that hallway? It ends in a locked supply closet. No exit, no second turn. I stood there for what felt like a full minute. Then I tapped my badge and checked the door logs. No entry recorded, no movement captured on hallway cams, but security confirmed. Exactly 2:19 a.m., another glitch. We don't talk about her much anymore, not because we're scared, but because sometimes in medicine you learn that not everything has a diagnosis code. There are patterns we chart, and there are patterns we feel. This was one of them. I've delivered bad news to mothers, coded newborns, held hands through final breaths. That little girl in the waiting room, she wasn't the scariest thing I've seen, but she's the one I remember. Every time I step out of trauma bay and see those empty chairs, I still glance over at the gumball machine, just in case.
Hello, friends, and thank you so much for tuning in. A special shout out to our incredible subscribers. Your support keeps these creepy, fascinating, and sometimes even comforting stories alive. But here's something to think about. Only about 30% of our viewers are subscribed. If you enjoy our content, hitting that subscribe button helps more than you might realize. It only takes a second, but it makes a world of difference. While you're at it, a like and share go a long way in keeping these eerie tales coming. Thank you again for being part of this journey. You're the reason we're here. See you in the next one, if you dare.
In the ER, you learn not to spook easy. Not because things don't get weird, but because if you panic every time something doesn't add up, you won't last long. But some patterns, they don't go away. Like the feet behind the curtain in Trauma 3. You'd see them plain as day, standing right there. But when you pull the curtain back, nothing, no patient, no shadow, no reason. I've worked night shift in emergency medicine since 2009, mostly trauma-adjacent care. Our hospital's ER is laid out in pods, trauma 1 through 4 in one bay, regular exam rooms branching off. Trauma 3 is our overflow room, standard setup, a monitor, a code cart nearby, portable suction, and a heavy vinyl curtain you pull shut for privacy. It started about 2 years ago. A float nurse, Jess, said she saw feet behind the curtain in Trauma 3. She thought we had a patient staged, so she prepped meds, came around the corner, and the room was empty. Curtain drawn, monitor off, nothing charted. She thought she made a mistake, laughed it off. But then a week later, it happened to me. I was covering as trauma led that night. 2:30 a.m., the usual lull. I came out of Trauma 2 after stabilizing a chest pain workup. Lights were low. I turned the corner and saw someone's feet beneath the curtain in Trauma 3. Shadowed soles just visible between the curtain hem and the tile. At first I assumed it was the psych hold we were waiting on. Maybe they'd shifted them from 5 to Trauma 3 without logging it. But the thing that struck me? No movement, no shuffle, no shift of weight. Just standing there. I walked in and pulled back the curtain, empty, monitor powered off, no linens disturbed, no patient tag. I even checked the room census. Trauma 3 was marked available. Still, I documented it in the incident log, not because I believed it was supernatural, but because we track all anomalies. Patient misplacement, documentation gaps, security protocol breaches. You cover your bases in this line of work. Over the next few months, 3 more night nurses mentioned it. Not in a dramatic way, just passing comments like, "Hey, did someone just go into 3?" Or I swear I saw someone standing in there. Always late, always when the unit was quiet, and always the same thing. Curtain pulled, shadowed feet under the hem, then nothing inside. We called facilities to check the HVAC in case movement or airflow could shift the curtain and cast shadows. Nothing unusual. We even checked adjacent lighting. No vents, no glare, no reflectivity from machines. Biomed found no issues. Security footage, angles too high. Trauma three's curtain blocks the view from the hallway cam. All you see is staff entering. Or not. One night we had a full trauma arrest come through. Motorcycle collision. No helmet. Massive head trauma. Blood loss on scene. We got Rossi in Trauma 3. Briefly. His name was Corey, 27 years old. He coded again. Less than 5 minutes later, we worked the full protocol, chest compressions, epi, bicarb, intubation, ultrasound, everything. We called time of death at 2:41 a.m. I was assigned post-mortem cleanup, bagged, tagged, transferred to holding. I sanitized the room myself afterward, partly to keep moving. You don't always process this stuff in real time. You just keep your hands busy. As I pulled the curtain closed for the final wipe down, I paused. Someone was standing there, feet, plain as day, facing into the room. I froze. I stepped out fast and called out, "Hey, we're closed in here. Give me a minute." No response. Pulled back the curtain. Nobody, not even footprints on the floor, and we had just mopped. Since then, we don't assign Trauma 3 unless we have to, not because we're afraid, but because, well, nurses trust patterns. Patterns help us save lives. Patterns also tell us when something's off. We don't call it a ghost. We don't blame stress. We just keep noticing. Sometimes we even joke. If you see the feet behind the curtain, it means a trauma's on the way, like a heads up from whatever's left behind. Nurses cope how we can, but I'll tell you this, if I walk by Trauma 3 and that curtain is closed, I look underneath, every time. You don't forget the ones who grab your hand like that. It was a late Tuesday afternoon, just past shift change. I was 4 patients in already, balancing 2 bed holds and 1 septic workup, when we got an elderly woman in through EMS, 84 years old. Alzheimer's, late stage. No trauma, just a fall risk. Nursing home staff said she'd tried to walk by herself again, got disoriented in her room, and tripped trying to find the bathroom. We placed her in one of the lower acuity bays, room 7, the one closest to the nurse station. That way we could keep an eye on her. Her name was Helen, small framed, white hair in a soft bun, wearing a pastel sweater set, not the usual nursing home gown. She still had a sense of pride about her appearance. That stays sometimes, even when memory doesn't. I did my usual full set of vitals, neurochecks, fall assessment, basic labs. She had a minor bump on the side of her forehead, but no LOC, and her CT came back clean. But she wasn't oriented, not even close. She kept asking what town we were in, asked if her dog had come with her. There was no dog. I sat beside her as she fidgeted with the corner of the blanket. She kept glancing toward the curtain like she expected someone to walk through. I told her we were going to take care of her and that her husband had been notified. And then, about 30 minutes later, it happened. I came in to check her IV site. Fluids were running slow. I was adjusting the pump, and Helen suddenly went rigid. Not in a seizure way. I mean emotionally. Her eyes locked on the curtain as it rustled. Then she turned, gripped my arm hard, and said, "Don't let him take me. Please, please, that's not my husband." At first I thought she was hallucinating. That happens, especially in late-stage dementia. Sundowning can start early. Sometimes they see shadows, or think they're in the wrong decade. But something about her face, the pure panic in her eyes. I paused. Who do you mean, Helen? I asked gently, glancing toward the door. No one was there yet, just the curtain shifting because someone must have walked past. Her grip tightened. Her knuckles were white. He's lying. That's not him. Don't let him take me. You can see it, can't you? I reassured her, checked her vitals again. BP slightly elevated, 144/92, heart rate at 98. She was flushed but febrile. She wasn't in acute distress, medically speaking, but emotionally, she was gone, spiraling into something we couldn't chart. Then the husband came in. His name was Carl, mid-80s, kind eyes, baseball cap from their church softball league, cane in his left hand. He looked worried the second he stepped in the bay. "Hey, sweetheart," he said, voice soft. "You gave us a scare." And Helen? She screamed. She recoiled from him like he was a stranger off the street, covered her head with the blanket, and yelled for security. "That's not Carl. That's not my husband. I've seen combat vets with PTSD. I've seen psych breaks that lasted hours. But this was a different kind of rupture. It was a betrayal that existed only in her mind, but felt as real to her as the IV in her arm. Carl was crushed. He looked at me, lost. She's never. We've been married for 62 years. I had to pull him aside. I explained the progression, that sometimes in dementia, especially with disorientation after transport in unfamiliar settings, patients may experience delusional misidentification, Capgras syndrome. It's rare, but I'd seen it before. Patients suddenly convinced their loved ones are imposters. She's not angry, I told him. She's scared. Her brain's trying to protect her from confusion it can't make sense of. This isn't her fault, and it's not yours. He nodded, quiet, said he'd wait just outside the curtain. Over the next hour, we gave her a low dose of Ativan, not enough to knock her out, just enough to ease her fear. We dimmed the lights in the bay, played her some old Sinatra from the overhead speaker. Sometimes familiar music can soothe, and I sat with her, just quietly. Eventually Helen calmed. Later, she asked me what my name was, told me she liked my earrings, then asked if her husband would be coming soon, like none of it had happened. Carl came back in gently, sat on the edge of the stretcher. This time she looked at him and smiled. "You came," she said. "Of course I did," he replied, his voice thick with emotion. "I'll always come." She didn't remember the fear, but he did. I walked him out later that night, helped him fold up her cardigan and find her left slipper, which had somehow gotten under the bed. Before he left, he turned and looked at me. "I know she's not all there," he said, "but I saw the way she looked at me, like I was a stranger. I didn't think it would hurt so bad. I didn't have words for that. Not really. So I just said, 'She loves you, Carl. Even when she forgets who you are, her heart remembers.'" Some stories in the ER don't end with a code. They don't end with a trauma surgeon shouting stats or a family member collapsing on the floor. Some stories just sit with you, quiet, deep, and they remind you that this job is more than medicine. It's humanity in its rawest, most fragile form. And some days, that's the part that stays with you longest.